Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Hello and welcome. My name is Sally Hodder. I'm from West Virginia University, and I am presenting episode 1 of 4 clinical clips at the 2024 Conference on Retroviruses and Opportunistic Infections. And I'll cover an interesting study of long-acting antiretrovirals in sub-Saharan Africa, and then we'll discuss 3 very stimulating studies on broadly neutralizing antibodies. Long-acting cabotegravir, an integrase inhibitor, and rilpivirine, a non-nucleoside reverse transcriptase inhibitor, are recommended for maintenance of viral suppression. However, there have been limited studies in sub-Saharan Africa and other parts of the world. Most of the data has come from North America. So this morning, the CARE study, which assessed cabotegravir and rilpivirine every 8 weeks versus continuing the standard of care antiviral regimen, was presented, and it was using a public health approach and performed in Kenya, Uganda, and South Africa. The inclusion criteria included that individuals had to be suppressed on antiretroviral therapy with a viral load less than 50 copies per milliliter, on stable antiretroviral therapy with no history of treatment failure, and also no hepatitis B infection. Importantly, consistent with the public health approach of this study, viral load was only performed every 24 weeks. Interestingly, retrospective archival resistance testing that was only done, it was not done at entry, it was done later, demonstrated that in the cabotegravir arm, 12.5% had rilpivirine resistance, with 8.5 of those percent being high level, and there was 16% cabotegravir resistance, with large proportion of those being high level. The results, 96.9% in the cabotegravir arm versus 97.3% of individuals in the standard of care oral therapy had viral loads that were suppressed at less than 50 copies per milliliter at week 48, meeting the non-inferiority standard of the trial. 2 virologic failures occurred in the long-acting arm at week 48. One was confirmed, and the retrospective archival resistance studies from bank samples showed no integrase or non-nucleoside reverse transcriptase in resistance at baseline. But at failure, rilpivirine high-level resistance was found. And you may remember that HIV subtypes, A6 and A1, were actually associated with high risk of failure in previous studies, Atlas and FLAIR. And interestingly, more than 50% of individuals in this study had subtype A1. And given the high rate of virologic suppression, I think what we can glean from this study is that really A1 was not associated with resistance. Moving on to the second topic in the session, which was that of broadly neutralizing antibodies. You know, HIV broadly neutralizing antibodies, I'm going to call them BNABs, really have been shown in the past to reduce plasma viremia, but selection of resistant variants has been described. And this morning's session actually presented therapy using BNABs in combination with antiretroviral agents. And that's really the first time that that has been done. The first study, which was the ACTG 5357, was a single-arm study that assessed safety and efficacy of BNAB term VRC07523LS, and I apologize for that. I'll just call it the BNAB from now on, which is really a CD4 binding BNAB. And it's been engineered to have really a prolonged half-life out to 38 days after IV administration. And it was given in combination with long-acting cabotegravir. It was a 3-step trial that really included step 1, which was sort of a 4-week lead-in with oral cabotegravir and 2 NNRTIs. And step 2, the BNAB, intravenous BNAB, was given Q8 weeks with intramuscular cabotegravir every 4 weeks, and this was given out to 48 weeks. And then the step 3 was a return to standard of care. There were 5 virologic failures, so that was 7.5% of the individuals, and that was defined as viral load greater than 200 at week 44. All 5 individuals who had failure had cabotegravir levels in the therapeutic range, and all had BNAbs that were 100-fold greater than the 80% inhibited concentration. One individual had an IC50 at screening near the study cutoff and experienced emergence of an R236K integrase mutation, which really raises the possibility of cabotegravir perhaps was given as monotherapy because the sensitivity of the BNAb was actually very borderline, and I think that really provides future thought for future studies. The second BNAb study was, again, a study combining BNAbs with antiretrovirals, and this one assessed the BNAb with lenacapavir for treatment, and it was presented by Dr. Iran. This study assessed safety and efficacy of lenacapavir with TMAb and BMAb in virologic suppressed folks highly susceptible to either TMAb or ZMAB, but not to both. I should say that the sensitivity of susceptibility to the BNAb was really defined by an IC90 of less than 2 micrograms per milliliter. This study was really in adults, and the primary endpoint was safety and tolerability at week 28. The results, 5 participants had treatment-related AEs. All were group 1 injection site reactions attributed and related to lenacapavir. There was 1 SAE that was not related to study drugs or procedures. And all individuals in the 30 milligram ZMAB arm remained suppressed, but 2 of the 4 individuals in the 10 milligram ZMAB arm had an RNA greater than 50 copies at 26 weeks. One of those patients resuppressed when the standard of care antiretroviral regimen was restarted, but patient 2, who actually had failure at week 20, which actually occurred after acute COVID infection, had a low-level detectable viral load really even after reinstitution of oral ART. In this study, there was no treatment-emergent resistant to study drugs. And the third study I'll mention just briefly was a study that looked at 3 different BNAbs and was not given with any antiretroviral therapy. It really these 3 BNAbs targeted different sort of epitopes, and 10 of 12 individuals who came in virologically suppressed, their antiretrovirals were stopped, but 10 of the 12 actually maintained virologic suppression, while 2 had rebound that correlated with baseline resistance to 2 of the BNAbs. Interestingly, these were long-acting. There were individuals at the end of the study who actually rebounded as well, and they really, that was attributed mostly to BNAb concentration increase, and there was both sensitive and resistant variants that were found. At the end of the session, Dr. Ricky Su really posed a very provocative question, stating that given that we have had years of experience with BNAbs, have spent a lot of money, and yet the studies that we just discussed actually had results suggesting that perhaps, should this be a strategy that we should continue to pursue? And I thought both Joe Iran and Babafemi Tairo gave really thoughtful responses to that BNAbs were still in their early days. Yes, they've been under development for a period of years, but it's very early days using them in treatment, and that they really provide a potential option for our patient, a new option. And that, finally Joe Iran really drew an analogy to the progress that's been made with injectable long-acting as sort of demonstrated by the CARE study, in that, people said, naysayers for years said, oh, long-acting injectables, that's not going to be very useful in resource-limited settings. And yet, as the CARE study demonstrated in resource-limited settings with public health, surveillance only every 24 weeks, these were quite effective regimens and really provide individuals the option. And as the study, as I said earlier, there were improved, the quality of life was much better in the long-acting. So in conclusion, I think that there is, much work to be done with BNABs. I think that these studies really bring options in the future, hopefully, for our patients. But there is much, much more work to be done. We need to define what the definition for susceptibility to BNABs is and how to most effectively use them in treatment regimens. Thank you for joining us for episode 1. And please refer to the landing page for slides, and be sure to come back tomorrow for the second episode from CROI 2024. Thanks again.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.